So I'm a GYN oncologist. So I'm by day I'm a cancer surgeon. I run clinical trials through systemic treatments, but I also happen to spend about half my time with research. And I want to talk a little bit about sort of kind of what we're doing here, and maybe get a little bit more of a clinical perspective. I will be talking a little bit longer because my friend and colleague Gottfried Konechny is not going to be able to join us. So if that's okay, Pete, I will sort of essentially fill in, the next hour or so, and try to sort of cover some of the things that he would have done. I think Oliver Dorigo, and another good friend of mine that's with you guys in Stanford, already gave a really good overview, I think, over a lot of the things that we're doing in GYN oncology. So without further ado, I always had like to have a couple of sort of pictures and have a little bit sort of a red line on take you guys on a trip. So I'm originally from Germany, so that's sort of driving into Germany on the German Autobahn, and we're sort of are a little bit on the road, I think, to precision medicine, or maybe more than a little. And one of the things I will focus on here is the title "One Cell at a Time." So I have no relevant disclosures for this presentation. So I essentially have 4 different parts, and it will be mainly focused on ovarian cancer because that's what I mainly do. I do some in endometrial cancer, but we're mainly focusing on ovarian cancer. I give you a little bit of a clinical background. I don't know how many clinicians are on this Zoom, and then I'll talk a little bit about sort of some stratified and individualized sort of therapies that we do, and then I'll mainly focus on this sort of large sort of precision medicine single cell program that we have here at the university, and I think can hopefully help to move things forward. So in terms of ovarian cancer, we've been driving a little bit on the Autobahn. This is in the far northeastern part of Germany, an island called Usedom. That's where my parents live, so kind of home. Good for windsurfing. So in terms of ovarian cancer, and this is, so I think some of the sort of lessons learned here is not only true for ovarian cancer. I think this is sort of uniquely true in oncology and probably beyond oncology. So I started my residency at Mayo in 2006. So if you just look at sort of hard outcomes in terms of ovarian cancer, we have made some progress, but overall is still pretty dismal, the prognosis. And that's true, unfortunately, for a lot of examples in oncology at large. In terms of ovarian cancer, so when I started, the main way how we classified those was with, and we've heard some earlier already, we classify them based on histology, meaning it's how do they look under the microscope, and there are 4 different types. They have distinct molecular features. In terms of sort of clinical reality, and again, that I think this is true for the majority of treatments in oncology, maybe even in medicine. So if you look at those 4 different subtypes, so the agreed upon systemic treatment worldwide is essentially they all get treated with the same chemotherapy. So you don't really use different treatments for different histologies. It's a little bit of caveat to it. There's some additional agents like bevacizumab. There's some PARP inhibitors. There's different ways of giving the chemotherapy, giving it IV, giving it intraperitoneally. But the bottom line is that most of these things are really treated one size fits all. So you have essentially one diagnosis, and they essentially treat it all the same. So what are the sort of the clinical problems that I face on a daily basis? The clinical problems are that while most patients respond to initial treatment, ultimately the vast majority, meaning about 80% recur. By the time they recur, we cannot no longer cure them. They can live for years, but it does require constant treatment. But cure is typically not possible anymore at that point. And one of the frustrations is, and Oliver showed a little bit of things like TCGA before I was fortunate to be part of some of those projects. We have learned a lot about the biology, and we've heard all about today identifying different targets and potential drivers. But the reality is still that majority of patients with ovarian cancers die within 5 years with drug-resistant disease. So in terms of it, just to sort of illustrate that a little bit, if you look at sort of, this is sort of a typical sort of disease course. So you start with the initial treatment, which consists of surgery and systemic chemotherapy. And then you have typically, like I said, about 80% of patients recur, typically within like 18 months or so. And then you do a second line of treatment, third line of treatment, fourth line of treatment. You sometimes do surgery again as another sort of line of treatment. But ultimately, you will sort of get more and more resistant disease that ultimately is not going to respond to anything. So it's this kind of concept of adaptive response. So there's essentially two ways clinically if you want to go about it. So one would be, ideally you would, if they recur, you would still figure out a way to cure them. You cure them first time around, or you figure out a way to delay, if you can't cure, at least delay some of these adaptive responses biologically. So if you look a little bit more in terms of, there's certainly ways how you can sort of systematically go about that, and we've heard a lot about that today. You can look at different pathways, and you can try to understand things better and try to sort of group and stratify patients and hopefully identify major drivers and major pathways that ultimately determine the outcome. So that's sort of the theory, and that's kind of where we would all like to go. So how do we get there, and where are we right now? So this kind of brings me back. This is actually where my sort of personal journey started as a medical student in Germany, and I was in a bunch of different institutions from my medical school. So when I sort of started with this, what kind of came about was sort of molecular attempts to molecular stratify patients into different groups. And Oliver showed this earlier. Like I said, I was fortunate to be part of the Cancer Genome Atlas project, and this is the work that we published out of the endometrial cancer group, and that work, which has really led to, we published it 10 years ago. So this is now part of the WHO sort of global classification of endometrial cancer. So there is now a molecular translated classification. We still haven't quite figured out which patient benefits from which treatment. Those studies are ongoing, but there is some major attempts, at least, while not personally individualized treatment. I would say it's sort of a first attempt into what I would call stratified medicine. Where you go away from this one size fits all and put patients in 4 different groups and treat these groups differently, rather than looking, for example, at histology or other sort of more traditional ways to stratify patients. In ovarian cancer, there's been a very similar approach and a very similar concept that we have been trying to translate for quite some time now. Those are gene expression array heat maps that essentially suggests that based on a gene expression level, there is likely 4 distinct subtypes of high-grade serous ovarian cancer, and you can see those. The names were given based on those genes that were overexpressed. In theory, this I think is sort of also an initial start, and our group was the first, because in TCGA there was really no prognostic relevance of those 4 subtypes because the follow-up wasn't long enough. Our group was the first to show that there actually is prognostic relevance of these groups, suggesting maybe there's really some true biologic differences between those groups. Having said that, when I put my clinical hat on, you can see statistically they separate if you look over 10 years, but the reality is all those patients have really poor outcomes. So clinically it's not that useful, because you wouldn't sort of de-escalate treatment or sort of change something if you still have relatively poor outcome. So I did also spend, we just had a great presentation from one of my colleagues at Mayo. I did spend about 8 years in Rochester as well. That's kind of how it looks like there most of the time. Although now in Minneapolis is not, you got to like the winter. But in terms of sort of taking this a step farther, so stratifying and individualized therapy in ovarian cancer, we've sort of taken some of those lessons learned and tried to further translate those and see whether you can you can actually find something that's clinically meaningful. So this, I think, is another good example that's not unique to a trial in ovarian cancer. This is the ICON 7 trial. It's a large phase 3 randomized trial where standard treatment was given in the standard arm, which was the carboplatin paclitaxel. The experimental arm had the addition of bevacizumab, which is a VEGF-A antibody that is an angiogenesis inhibitor. And I just came back from the large national ASCO meeting last week, and when you sort of see these large phase 3 trial data presented, a lot of them kind of look like this. So you have these Kaplan-Meier curves with progression-free survival. You can see that bevacizumab adds a little bit to that standard arm, but the reality is clinically is 2.4 months progression-free survival difference, meaning the time from when you stop until you have recurrence, you buy about 2.4 months, which clinically is not meaningful. If you look at the overall survival, it's essentially completely negative. And that, unfortunately, is true for the vast majority of drugs and trials that are tested. So we were fortunate to get our hands on about a third, about 425 of those tumor samples from that trial. And one of the things that we did, we sort of stratified them. We did gene expression arrays, and then we stratified them based on these 4 distinct gene expression based subtypes. And we hypothesized that there will be one, and sure enough, it was. This proliferative subtype has a lot of genes that are upregulated in angiogenesis. So you can see if you sort of do molecular analysis, while this is a very crude thing to do, you could start to potentially find the patients that derive the most amount of benefit. And you can see here you have 10.1 months. We had some updated overall survival data that actually translated to almost 28-month overall survival advantage, which clinically meaningful is probably anything above 6, I would argue. So you can see that if you start using some of those molecular data and add them on to really clean clinical data with a randomized phase 3 trial, you can start to sort of pick out the patients that most likely derive most benefit. So part of the issues, and I'm not a bioinformatician, but part of the issues with these things are, if you have 425 cases, you can do sort of semi-supervised or unsupervised clustering, put them in different groups. When I sit in clinic every day, I have a patient in front of me, and I have to put that patient into one of these 4 groups, and that would sort of refer to a single patient assignment. That is not as simple as you would think it is. So we have developed sort of much more robust models with, like I said, a lot of those things are way above my head. But if you develop models, you can get, with this kind of data, you can get to AUCs that are in the range of 0.77 single patient assignment. So if you think back, Oncotype DX is probably still sort of like the example that's always quoted to use to stratify early stage breast cancer patients. They were originally in that sort of range, 0.75. So clinically, anything above 0.75 is probably actionable. And that's kind of how good you can get about with this. So if you would do that, and we're currently validating that in another phase 3 trial, if this holds, then you could essentially identify 20% of patients that significantly benefit from upfront treatment with bevacizumab. You have this 40% group that derives a moderate benefit, but you also have a 40% group that derives no benefit whatsoever. So that brings me a little bit sort of further in on this trip and on my journey. You could see that's actually when I left Mayo in the summer of 2014. So it does get sunny and fairly warm. You can't see any snow here. So that's kind of when I moved to the University of Minnesota. And one of the reasons I came here was the University of Minnesota. I believe it's number 6 in the world now, supercomputing institute. It has a very strong health informatics division. and strong sort of sequencing cores with some pretty innovative, I think, technologies and forward-thinking people. And when I came here, that's sort of about the time when single cell sequencing was a sort of starting, and it's sort of in its infancy. But one of the things I wanted to do when I came here to build a prospective sort of like program that essentially leverage as much of this kind of molecular data and going beyond sort of bulk sequencing. And you can sort of appreciate when you look at bulk sequencing, you always get some signal, but this is derived of hundreds of thousands, if not millions of cells. When you do single cell type sequencing, well, you get much higher resolution. And from a clinical perspective, I can tell you, because we have learned this the hard way, we've run many trials in endometrial cancer and targeted trials where we looked at druggable targets using bulk type sequencing. And the reality is, just finding something doesn't mean that's necessarily going to drive the outcome. The reality is actually that most of the times it doesn't. So just because you find something that's druggable likely will not respond to whether somebody is going to benefit from that or not. And at least the hope was that if you get higher resolution data with single cell type analysis, you might be able to further identify what are really sort of the driving populations that ultimately determine the outcome. And that's kind of sort of the idea behind it. I always kind of like to show this slide to just put that in perspective. So when I do these surgeries, we remove pounds of tumor. And if you put that in perspective, if you look at a little piece here, there's still millions of cells. And when you look at one of those pathology blocks or slides, when you go further down, and then ultimate to the single cell sort of type level, you can appreciate if you have any sort of bulk analysis, you get a broad idea what's going on. But if you then think it's not only cancer cells, it's stroma cells, immune cells, it's a very, very heterogeneous mix of cells, like you'll see in a minute here. So the higher resolution you can get, and from a clinical perspective, all it takes is like one cell to survive any kind of treatment, and that will be the base of your recurrence. And to me, it makes sense. You have to understand it, probably on that kind of level in order to sort of really draw some meaningful conclusions. So this is just sort of like an overview of how this prospective sort of, it's kind of set up as a prospective sort of like a single institution trial. So all patients that come here with ovarian cancer get enrolled in here, and we essentially do a vast array of molecular analysis. We have PDX models in these patients, but the real core is sort of that we have single cell analysis. We have them now in different time points, before, after chemo, at the time of recurrence, again, with this overarching goal of to really understand what is adaptive response and why is it that so many patients recur, and what are really the populations and the ultimate drivers that you would have to address in order to change the trajectory. So when and this is almost kind of laughable from today's perspective. This is the first, my group was the first that successfully did single cell sequencing in ovarian cancer. This is the first patient we did in 2016. We published it in 2017. That was using the C1 platform at the time. So this is all we got. We got 66 cells. Those are epithelial cells. And one of the first questions we asked was, going back to this initial attempt that we've done with these as TCGA subtypes and trying to translate some of those, what if you look at an individual patient at those subtypes, and you can appreciate each dot here is a cancer cell, and if you plug in those genes, you can see that even from this sample, this patient is all 4 subtypes at the same time. And that comes back to this prior thing that I've mentioned. This works if you have a large set of patients, but if you have an individual patient, it is kind of hard to, how you're going to call this one now. It has essentially all 4 subtypes. So yeah, you can, and there's an effort using nanostring with some of my collaborators from British Columbia. They have an assay up and running, and we've sort of used it in the clinical trial, but they always can just give you some probability which subtype they are, and we just said, well, the one that's most likely, that's the one will be how we call it. But you can just appreciate even here it is not that straightforward. So the other thing that we then started doing, so this is now sort of like the next generation, and we've mainly used the 10x platform now, which can give you anywhere between 10 and 15,000 cells at a time, and the way it is essentially works, so we'll get them straight from the operating room, and they're processed fresh, so they're within about 50 minutes of ischemia time. They get dissociated, and then they get essentially run on the 10x within about 2.5 hours or so from coming out of the operating room, which is a pretty unique setup that we have here. And I think part of the reason so few people have even attempted to do this. But when we started, one of the first questions was, or one of the first problems we ran into at the time, there wasn't really very good sort of algorithms and scripts and ways to analyze some of these data. So we sort of developed some of our own. We sort of using now sort of like a mix of a lot of these things. But one of the first questions I had from a clinical lens, first of all, how many different distinct subgroups of cells can you actually identify? Not only cancer cell subpopulations, but cells in general. So this is an NMF-based sort of tool that some of the bioinformaticians here developed and published, and it runs very similar than kind of like some of the bulk NMF tools are. So it has, maybe to me it feels it's probably a little bit more objective in terms of how it sort of defines things. Because one of the problems that we ran into initially with some of the single cell things, you can change all these different parameters on some of these like pipelines like Seurat and other ones, which gives you a vastly different sort of even estimations on how many distinct subpopulations of cells are here. So if you look at this example, for example, this is one patient's example. Those are the distinct sub clusters of cells, and you can see you get like a saturation. So for this patient, the inflection point is somewhere around 25 or so subtypes, subclusters in this one sample. You can see in figure B. Can you actually guys see my cursor? Okay, so in the B here, you can see how many cells are actually in each of those clusters. We did then just the traditional sort of more dendrogram kind of things, because we kind of wanted to try to understand what actually does this do. And you can see here, you have essentially the first separation. If you look at these sets, you have 15 epithelial type subpopulations, which are essentially your cancer cells, and then you have immune and stroma cells. So when we kind of did that, we said that seems to make sense. When you look a little bit more in detail, those and look what are the metagenes for these distinct sort of subpopulations, you can appreciate here those are the 15 cancer subpopulations, and there's some in there that are, so for example, like HRD type. We've heard about that earlier subpopulation. You have some that are more like cancer stem cell like, whether you believe in that or not, that's another discussion. You have some other ones that are sort of hormone receptor driven. But when I first saw that and thought about this clinically, so in this patient, there's 15 distinct cancer subpopulations. The question then really is, and if you even just look at the HRD population, so it started to make sense. Well, patients, for example, respond to PARP inhibitors, but it's only one of those subpopulations. So you still have those 14 other ones. So from a targeted and clinical perspective, you would have to combine 15 different targets to eradicate all of these populations, which clinically is impossible. You can maybe combine 3 targets, and that, I mean, the toxicity that you get by that point is typically too much. And then you can see on the other side, these were then the immune populations as well as the stroma populations. So the next thing then we looked at, so is always a good question, is where did this cancer actually come from? So you can now do analysis with these kind of data. For example, it's pretty well established that ovarian cancers actually don't start in the ovary. They start typically in the fallopian tube. So when you compare with fallopian tube epithelium, you can see, those cancer populations, those 50 are actually closer to a fallopian tube. So you can start really sort of like making some more sense on this kind of more high resolution level. what we did then in the next step, because to me clinically the most important question was, well, we sort of understand the landscape in naive tumors, and we've done that in about 130 patients now or so. So we have a pretty good grasp of that. But to me, the $1 million question was, what happens if you give the same patient and sample again after you've given chemotherapy? So what happens when you give chemotherapy to those 15 populations? And that I think is really critical to do this. And we've seen this before in some of these examples here, that you really sample at different time points after different treatments to really understand what happens on a biologic levels, what happens on an individual cell level. And I'm just going to show sort of like one example here, but we've done that now in quite a few sets where we looked before and after chemotherapy. So this is before chemotherapy and this is after chemotherapy. It's always the same patient. So you can see here, so this patient, for example, we had about 7 distinct sort of subpopulations of cancer cells. After chemotherapy, you could identify about 13 distinct subpopulations of cancer cells. So one of the questions that we had is, where do they come from? So what essentially happens when you give chemotherapy? And it does appear, and that I think is actually quite encouraging, that chemotherapy can eradicate the majority of these populations. But we typically identify 1 or 2 populations in these patients that for a variety of reasons are probably inherently already resistant to chemotherapy. Or I don't know that they're really resistant, but they can essentially withstand to a certain extent chemotherapy. So we're following a couple leads right now, and I'll show you some a little bit here. But this appears to be universally true. But what you can see here, so if really in this patient it comes from these 2 populations, now you have 13 new populations. I told you earlier, anybody that recurs currently with ovarian cancer we cannot cure, and this might be why. So you essentially have these populations that fan out into 13 new populations. They're all driven by very distinct biologic mechanisms and pathways. And even if you could identify those 13 pathways, which you can, I mean, I've showed you that earlier, you clinically could never combine all of these targeted agents if that's the route you would choose. Having said that, there might be another way. So if we, in terms of sort of pathways, so there's a couple of ones that are sort of recurring, and like I said, we're sort of chasing a lot of those down now. STAT3 was one interesting thing that we found is, and that seems to be a fairly universal trait among different sort of patients. Interferon gamma seems to be upregulated in these cancer cells that are resistant or more resistant or resilient to chemotherapy, which one of the functions of interferon gamma is that it can sort of reduce essentially growth, and by doing that you would not be sensitive to chemo if you're non-dividing cell. And we've sort of showed that we're looking at the different sort of cell cycle stages. That's some of the beauty of this sort of high resolution single cell type work. You can sort of do that for individual cells, and it does appear that that's a common theme. TGF-beta is another one. There is actually more patients than we thought that might actually be heavily driven by hormone and pathways like estrogen, and that again goes back to, in my field, people have tried hormonal treatments in ovarian cancer in unselected patient populations and have essentially discarded it because there was really no response. But you can start to appreciate when you look on higher resolution, there is actually patients that actually might benefit from that, but you have to be able to identify those. So we've taken some of that data that now in large cell line panels those are from Gottfried Konechny at UCLA. They have like 40 some cell lines, and use some of those genes that we have identified for these sort of resistant type populations, and we can see there is actually, you can translate that. So those are more resistant to the traditional chemotherapies. if they have these genes. So essentially, we're trying to find sort of cell line surrogates for these resistant type population, and it actually tracks pretty nicely. So they're all more resistant if they have more of those genes that define those populations. We've then taken that, gone back to this ICON 7 gene expression core that we have. There's also, it does appear that those genes that define these resistant type populations correlate with outcome. At least sort of there's a trend there that there seems to be like a separation, suggesting that the more of those populations you have, the worse you might potentially do, which to us was reassuring that there might be something really here clinically. If you try to sort of translate this in terms of what does this mean clinically in an ideal world? So what we believe is that I've showed you, once you've given chemotherapy and somebody recurs and you have all these new populations, it gets very, very difficult. Having said that, if you think about the initial treatment, you can eradicate majority of the populations, but you might need something in addition to eradicate those inherently already resistant or more resilient type populations. So I don't think I will have to not do surgery anytime soon anymore. So I think we'll still keep doing surgery and physically remove as much of the tumor as we can. I think chemotherapy is here to stay, but you need something in addition, I think, to go after these kind of populations that are, withstanding this kind of traditional treatment. So this is a picture of the University of Minnesota, also taken in the summer here. So how can we sort of take this sort of a step further now? I told you earlier that I'm involved in a fair amount of clinical trials and sort of like early sort of phase 1 trials. Ultimately, we want to translate these things clinically. I've showed you about the single cell sequencing, which I think can be used for hypothesis generation and really trying to drill down on some of these things and understand these things. But clinically, there's few places that could ever do this clinically, if at all. So in order to translate this more now into the clinical realm, there's a new technology that came around also a little while ago now. It's called single nuclear sequencing, that can essentially take a snap frozen piece of tissue and essentially isolate the individual nucleoli, and then you can sequence those similar than the fresh single cell sequencing. You lose a little bit of information, but you get pretty close to what you can do with fresh single cell sequencing. What this does, if you can get access to snap frozen tissue from clinical trials, this opens it up now to potentially even integrate that into clinical trials, and that's exactly what we're doing. This is some initial work where we just tried to sort of like get a grasp. We took a couple of patients where we had the same piece of tissue. One we threw in liquid nitrogen, snap froze it to do single nuclear sequencing. The other half we did fresh single cell sequencing, just to get kind of a feel how does the data differ. And there is some subtle difference, mainly in the immune compartment. You have actually an artificial enrichment of immune cells when you do fresh processing, because when you dissociate the cancer cells and the stromal cells and the immune cells are not really sort of attached, and they just separate easier. So you always have more of those than actually of the cancer and stromal population. So you probably have a little bit of an enrichment from that perspective. Single nuclear sequencing probably gives you a little bit more accurate reflection of the true immune environment. So we have, after we established sort of that technology, we've then taken samples from a phase 2 clinical trial, flatland trial, that we ran many years ago, called the Trio 14 trial. It's an upfront trial, randomized, placebo-controlled, where we tested an IGF-1 inhibitor to the addition of the standard carboplatin paclitaxel. It was unfortunately a complete negative trial, kind of sort of similar like I showed you earlier with that ICON trial. So this is just the trial. Those are the results. But we were fortunate that we have collected a fair amount of fresh frozen tissue from those patients, and we started with 139 of those. But what we were hoping for, we wanted to have somewhere we had enough tissue that not only could we do single nuclear sequencing, but we also had bulk gene expression array data. And the thought was to start sort of like translating some of these things from that higher resolution to sort of compare what can you see on the bulk sort of expression level. And we ended up with, we ran 55 and we had a bunch that failed for a variety of reasons, but we did get data in 46 of those patients. That's just kind of the sort of clinical breakdown of those patients. That's just kind of an overview. And you can sort of appreciate the blue here is again the cancer populations. And then you have sort of the immune populations, you have the stroma populations. You can appreciate we got a pretty good yield in terms of quality. And this is sort of forming the basis now. We're working on now integrating some of these technologies into prospective clinical trials where we do CT-guided biopsies and would run these kind of analysis then on those samples before and after different treatments. When we looked at just in terms of the heterogeneity and sort of the breakdown, you can sort of see this is just sort of the different cell types. But what I was much more interested in terms of sort of clinical utility of this. One of the first questions I asked, I've showed you earlier the best models we could build with clean phase 3 trial data and predictive prognostic models. So we got in the range of 0.77. But one of the hypotheses we said, well, if you put in much higher resolution data and more data, can you get better with your prognostication and sort of stratification of patients? And this is, again, different time points here because of its few samples. I don't want to overstate this, but it appeared at 36 months, which that's in terms of follow-up and events, kind of what we were looking at. It appeared when you compared the bulk, which is here in blue, and looked at the single nuclei, you could build better models with AUCs for a single patient about 0.86. So you're starting to get higher, which I think all we can take from that yes, it might be possible to really derive more clinical meaningful data from higher resolution analysis like that. And I think that's all we can say. Overall survival, the follow-up wasn't long enough. It's few cases, so I don't know what that means, but at least it appeared that there might be something there. So the next question then, and again, I'm not a bioinformatician, so some of the random forest and the group that I work with, I think they hold about 40 patents in sort of like their own algorithms and prognostic, predictive, and causal modeling, and have been using AI for 25 years or so. So like I said, way above what I understand, but they ran essentially a lot of these kind of models, because one of the questions I had, I said, well, if maybe you can get more information, then one of the question was, well, what sort of cell populations, what drives the outcome in these patients? And the thing that was actually quite fascinating, you could see here, and again, it's not very many cases, but it appeared that the cell populations, and it's sort of the interaction of these, the endothelial cells, which are the cells that sort of line the blood vessels, the epithelial, which is a cancer population, not a big surprise that that's important, and then the fibroblasts, and sort of the proportional interaction of those seem to mainly drive the outcome. Why could that be potentially relevant? Well, that's what we're actually doing right now. We haven't done that yet, but endothelial cells are sort of the target cells of VEGF, that bevacizumab, that inhibitor I showed you earlier, where we had this like negative trial and we could start to tease out patients that benefit. That's what we're doing right now. So we believe that when you actually just look at, and this is probably 0.01% of all the cells, so it's essentially needle in the haystack, if that. You could potentially envision using now the genes, and that's what we're trying to do, that define the endothelial cells to maybe identify the patients that derive the most outcome and build even better models with higher AUCs that clinically could even be more meaningful. So I think this starts to illustrate that you can use these high resolution things, I think, to generate hypothesis and then really know what you're looking for once you get to sort of like less higher resolution, like bulk, sort of traditional bulk analysis. Another sort of example I would like to show in terms of clinical trials. So one other thing that has been in ovarian cancer, immune-based therapies unfortunately haven't really gone very far in ovarian cancer, and most sort of attempts have failed. Unfortunately, one of the things that was tried is just single agent checkpoint inhibitors that are very effective in melanoma. Oliver showed us earlier they're very effective in MSI unstable, POE-mutated endometrial cancer, but in ovarian cancer, the unselected response rate is somewhere in the range of 10 to 11%. So we're running 2 trials. One is using those TCGA subtypes to try to enrich those patients. So that's one way how you could get around it, try to pre-identify patients most likely to benefit, because those 10% of patients, they can derive some significant benefit. I've seen patients on years of checkpoint inhibitors, but the question is how to find them. So that's one way to do it, and we haven't completed that yet. We've run another trial where we added a methylation modifier to pembrolizumab with an idea that should sort of like improve the response rate and the expression of PD-L1. So you could do combination trials, but so far none of that has sort of really sort of panned out. So what we then thought to do is to try to sort of understand it on an individual cell level and try to see if we can make sense out of how could you potentially identify those patients. So we took our single cell data and looked at, I think this is like 30 patients we've initially looked. So the first thing that we looked at was essentially PD-1 and PD-L1 expression. Those are the targets of checkpoint inhibitor like pembrolizumab, and that was a very simple question to see where do you actually find this expressed. PD-L1 has also now shown in clinical trials is not a good predictor in ovarian cancer. You could argue it's not a good predictor in any cancer, but it depends whom you talk to. And at least in ovarian cancer, you can see why that's the case. So those are, again, this is one patient example. Those are all the different cell populations going to be done is a cell. If you look at PD-L1, it's completely unspecific. It's expressed by literally any cell that you can see, any cell population. So if you want to have something that's a good predictor to stratify patients, well, this is probably not it. And if you look then at the other target of where actually like a checkpoint inhibitor like pembrolizumab would work, which is PD-1, well, you can see it's actually pretty specific. It's only CD8 positive cells. And we then went back to that icon cohort I've shown you a couple times of the gene expression data set to see if you look at that, take that needle again and look now in the sort of into the bulk data. Is it prognostically relevant? You can see PD-L1 again expressed literally in every cell population is not predictive at all. PD-1 actually is prognostically relevant, which was kind of actually surprising to us. But it does appear that it is, which would then further suggest maybe that'll be a way to sort of stratify those patients. We've tried to sort of put this, and it's unfortunately a little bit more complicated than that, but if you put all this together, so when we looked at these initial 30 patients, we had 4 out of those 30 patients, which happened to be 12%. So we're now trying to get our hands on clinical trial specimens that were treated and to test some of these things. But the sort of the theory would be that you look at PD-1 and CD8 positive cells, and then PD-L1 likely only in the tumor-associated macrophages. And if you do that, then you get about 12% of cells. I showed you earlier the unselected response rate is 10 to 11%. So it's in that realm. Again, I mean, it needs to be proven whether that's the case and whether you could even have something that's easier clinically deployable. If it's only expression, mRNA expression of PD-1, well, then you could just do like a PCR or something like that. But I don't know yet whether it's going to be that simple or not. But it just, again, I think illustrates the power of this to really identify the needle and the things that really drive the outcome and help to identify those patients. We have now taken this with the latest development, or I guess it's been a while now, but we sort of do a fair amount of spatial sort of analysis now on all of these samples, because the one thing, the single cell I think is very powerful, but some of the limitations is you don't really know exactly what the sort of like three-dimensional interactions of these populations are. Probably skip over this. So I think that you can summarize that you can identify populations, distinct populations, potentially new targets, and understand which are the ones that you need to go after, because those are the ones that ultimately drive the patient's outcome. So how do you do that actually? How do you sort of go after some of those? And I think one of those ways to do that is this concept of the antibody drug conjugates. Oliver, I think, has told us a little bit about folate receptor alpha ADC was just approved in ovarian cancer. So I think this could be sort of one way to do some of these things. If you can, for example, identify populations that are resistant or resilient to chemotherapy, if they share a common surface target, you could design an antibody and build an antibody drug conjugate. Like you can see here, this is sort of the antibody. You have a linker, and then here, and then you have the payload, which is typically a chemotherapy. Most of the ones we've been using now are sort of taxane-based chemotherapies. But the idea is that you have something that's much more specific. So it's kind of like a targeted chemotherapy. And the one thing clinically, I think people sometimes don't stress enough, chemotherapy is very effective for a lot of cancers. In theory, you can cure almost any cancer with chemotherapy. The problem is that you run into toxicity because it's unspecific. So you essentially target every cell in the body, and that's where you have your limitations. You just can't get doses that are high enough to really eradicate all those cells. And this again could be one way to get around it. Those are some slides. They're actually from Gottfried Konechny, and one of those targets that was identified is called Claudin-6, and that's actually not a novel target that was identified about 20 years ago, actually from the two founders of BioNTech. And people have sort of tried to use this target. It's a tight junction molecule. There's, I think, about 27 tight junctions. Claudin-6 is one of them. The thing that's unique about Claudin-6 is that it's only expressed in cancers. You cannot detect it in any normal tissue, and that makes this quite unique. So Claudin-6 was then further explored, and this most of that work was done at UCLA. We have collaborated with some of these things and helped with some of these analysis. So one of the first things was to see which are sort of the cancers that have the highest expression of Claudin-6, in order to sort of like identify target populations for clinical trials. And it happens that ovarian, testicular, and actually uterine cancer are really the ones that have sort of the highest expression, and those are the ones we sort of like are going after right now. This is, and I think this is really remarkable. When we first saw that, we thought that almost can't be true, but this is essentially RNA-seq, so gene expression data from normal tissue, and you can see here is 0, and that's for Claudin-6, and it's literally, you cannot detect it in any normal tissue. There's some additional work that will be published pretty soon here, where people have actually looked through embryogenesis, and you essentially have it initial in embryogenesis, and you will lose Claudin-6, gets essentially completely downregulated and shut down by the time at the time of birth. So you really cannot detect it in essentially anybody past birth, unless it's a cancer that sort of selectively upregulates that again. So this is just we could probably skip over that. So after that, there was some encouraging rationale to pursue this with at UCLA and this startup a antibody drug conjugate was designed against Claudin-6, and initial sort of preclinical activity was quite encouraging. What was actually pretty remarkable and is that even by itself, the antibody without a payload and without a chemotherapy on it already had some anti-tumor activity, which the earlier studies about 20 years ago, there's really no activity with any of the antibodies available at the time. So this is this phase 1 trial that is run by Gottfried, and I'm the PI at the University of Minnesota and in collaboration with Mayo. So we have opened at 3 sites now. It's a phase 1 trial. We're still in the dose finding part of this, but we've just presented that data at ASCO. We're starting to see some not only very limited toxicity, speaking to that it seems to be true what we had sort of postulated, that there really is no expression in any normal tissue, hence there's really very little toxicity, but we're already starting to see quite a bit of encouraging anti-tumor activity even in that dose finding, which in itself is relatively rare, but so far this looks really promising. We're sort of like at the point where we almost have identified the dose, and then there will be sort of expansion cohorts in ovarian and likely endometrial cancer. I could probably skip over that. Oliver has mentioned, so that's this folate receptor alpha that was just approved in ovarian cancer. There's another one, NaP2B is sort of another one. This is sort of Claudin-6. So conceptually, you could consider to identify different surface targets and then really design those antibody drug conjugates against that, and especially when you're sort of confident you have identified the populations and ultimately drive the outcome. So one other thing that we've done here, and we can go over this, I don't know how many of you have sort of heard of it, C-Bio Portal. It's a web-based browser that came out of Sloan Kettering, and a friend of mine, Nikki Schultz, has developed this, and it sort of came also part out of TCGA, but it's essentially a web-based browser that they use clinically, and we have this now here and start sort of integrating that into clinic, because you can generate all this data, whether that's bulk or single cell or any of these things, but you have people like me who are clinicians that sit in clinic. You need to be able to make this sort of like really sort of distillate and find really the things that are clinically meaningful, and have a way to sort of really present that. And this is sort of one way how you can do that. So you identify what likely it could be drivers, what is potentially druggable. You link it then to clinical trial databases and drug databases to really start to sort of make sense out of some of this information. So that brings me sort of to the last part here. So this is just, I want to share, we sort of shared that before, but this is really where we got approached by Pete, and this is sort of an example of how could you, on an individual patient level, we got from Shirley, we got a sample from a malignant pleural effusion that Gottfried took at UCLA. He overnighted it here. This was again a high-grade serous ovarian cancer case. We performed then single nuclear sequencing because they sort of snap froze. They snap froze it. If we would have sort of just kept it viable, I mean, you probably would have had too much change in expression. And we've sort of never done that before, and we had no idea whether this is going to work or not. But sure enough, it did. So we got 16,431 cells that we did the single nuclear RNA sequencing. This is just sort of some of the sort of sequencing readouts. But more interesting here, I think, is this is essentially what we got from this sort of real-time sort of analysis of this sample at that time. So you have 16 distinct subpopulations. Like you can appreciate here, those are again all the cancer subpopulations, and those are the annotations here again, also with sort of like the different sort of cell types probably go over that. So the question that we had then, and we had never really done that before, sort of, but to really distinctly just start looking, what are the things that we know, what are the targets, and how are they on an individual single nucleus or individual cell level distributed within those cancer populations. And we started with checkpoint inhibitor, and I think Shirley has gotten pembrolizumab at one point as a little bit of response, I think, initially. But so at this time point, when we got this sample, when you just look at PD-1 and PD-L1, you can appreciate there's essentially none of those cells really express that. So again, we haven't tested at this point, but that would suggest if those targets are not there, that likely I don't think would be a good option. We have looked, there's other ways to look at checkpoint inhibitors, sort of like prediction whether it works. There's this 18 gene interferon sort of stress gene signature that Merck has developed. It's mainly out of melanoma, but we sort of ran that too, and we didn't really see much there either. Again, that comes also from bulk. I don't know whether you could translate it or not, but it also would suggest that this likely this wouldn't be a good avenue. So we looked at other checkpoints. So CTLA-4 and its targets, you could see there's some in the tumor. So compared to the PD-1 PD-L1 axis, this might potentially could have been maybe a better checkpoint to target at this time point in the tumor evolution. We looked at other things. So we work quite a bit with Joan Brugge and her group now in some of the single cell data. They have a huge interest in sort of the OXPHOS pathways and some of those metabolic pathways. So you could see there is a tumor population here, the cell population that potentially is driven by that. We looked at other targets, CDK4/6. We're running some trials now in ovarian cancer and endometrial cancer with that. So there is some. One of the things that was actually quite striking is that HER2, which none of those things you would traditionally ever think about in ovarian cancer at this point in time, but at this point in time, you did see a fair amount of HER2 expression on an mRNA level, which I think could be potentially another target. And what I think is key here, it seems to be fairly universal across those populations. So you don't just have one population, kind of like you have here with the OXPHOS. So that maybe could be an avenue. We looked then at some of the other ADCs. So the folate receptor alpha, you don't really have much expression here. What was quite striking, you have estrogen receptor. Remember, I've mentioned earlier that there is probably a role for hormonal manipulation in ovarian cancer. We just don't know how to identify these patients well. Here in Shirley's sample, you can see actually almost all of those cells have some estrogen receptor expression, and going back to the CDK4/6, kind of like it's done now in breast cancer. So you could combine those. So that would be another potential thing to consider. There's an ADC against TROP2. You can also see you have a fairly universal expression across all of those different populations here, which again could be another potential target. So in summary, what is needed to bring more adaptive response persistence into clinics? So I think what's really needed is these high resolution type analysis, which cost a lot of money, a lot of brain power and effort. But I do believe that that's really necessary to understand what are the subpopulations that ultimately drive the outcomes. So really these kind of analysis, and then identify these things that are really driving this. And once you have identified them, well, you can design ADCs or things against that in order to really sort of test that and translate that. But one thing that I always like to stress, and I don't think is done enough, and that's why I think this is like so unique what you guys have here. We don't really sample enough. We need to sample at all these different time points to really understand what is going on and what it is that you have to go after, and it has to be real time. So if you go back, and we learn this now, the longer we do this and the more time points we have, these tumors change every single time. After every treatment, you really create a completely different tumor. And like I showed you, that's how it fans out into these new populations. This does happen, really at all these different time points. So in summary, we really have to sort of account for the heterogeneity and really understand what drives the patient's outcome at the end of the day. And that is, I think, what we have to really focus the effort to go after, identify those subgroups, really get biomarkers. I find ways to find these needles and then translate that into better targeted therapies, and identify really sort of also these predictive signatures and ways to identify these patients. Except we have tested a lot of things, but if it's unselected, it likely will not work in all of these patients. And really, even on a larger scale, like we've seen endometrial cancer, also understand whom to treat and whom not to treat. So I'd like to stop at this point and really like to thank our patients that really participate in these things and donate their tissues and make a lot of these things possible. A ever-growing list of collaborators and